Hello, my name is Friederike Keating, and I have the pleasure of sitting down with Dr. David Wolinsky today to discuss the nuts and bolts of the business of cardiology. I know some of our listeners have firsthand experience with this topic, while for others, it's still full of mystery. They sure didn't teach us much about business in medical school. I am an academic cardiologist, program director, and director of nuclear cardiology at the University of Vermont, and I've been interested in health policy for a number of years. I currently chair ASNC's Health Policy Committee. Today, we will try to get some answers about the business and health policy side of nuclear cardiology, and with me to ask the questions is Dr. Ahmed Abuzaid. Sami, will you briefly introduce yourself?
Thank you, Dr. Keating. Hi, everyone. I'm Ahmed Sami Abuzaid, a clinical imaging cardiologist in Alaska Heart and Vascular Institute. As a clinical cardiologist, so focus on hypertrophic cardiomyopathy and cardiac amyloidosis. I'm a current LDB member at ASNC and a candidate of the Master of Science of Healthcare Leadership at Brown University. Welcome, everyone.
Thank you. And now it's my privilege to introduce Dr. David Wolinsky. David is director of the Cardiac Amyloid Center and section head of nuclear cardiology at the Cleveland Clinic in Florida. And he is also the past president of the American Society of Nuclear Cardiology. David, you were ASNC Health Policy Chair for many years. Why was this focus important for you, and why should it be important for others?
First of all, thank you for having me. And this is my 40th year in nuclear cardiology. So I've really seen the field evolve. Prior to being at Cleveland Clinic, I was up in Albany, New York, where I directed nuclear cardiology, and I actually set up the first outpatient nuclear cardiology lab between New York and Boston. And that led to setting up about 4 or 5 labs in the area. So I've always had an interest in nuclear cardiology. The field has changed. Years ago it was a burgeoning field with a small number of people really focused in the Northeast US. We would meet on a monthly basis and have these monthly meetings. We called it the New England Nuclear Cardiology Working Group. And we talked about the nuts and bolts of what needed to be done to promote the value of nuclear cardiology. Before it was health policy, we had actually what was called the Community-Based Practice Committee. Nuclear cardiology has always had a very good marriage between private practitioners and academics. It's never really had any of the town and gown phenomenon. So we've always really worked together, understanding the needs that we have. Now, really what I saw, my goal to bring the knowledge of academic nuclear cardiology to the community and make sure they realized what the value of it was, why we did these testing, what we thought the value of it was. I think nuclear cardiology evolved primarily to diagnose and then evolved into risk stratification. And I think that really was important. We did a lot of patient education. When we first started, it was really bring the technology and the science to the community. That's changed over time, and the needs that the Health Policy Committee has handled has changed over time.
David, that is a great answer. Now, in nuclear cardiology, are a diverse group of physicians and providers. But what we should all know about billing and reimbursement in this evolving field?
So, you kind of look at the role of who makes the decisions. When we first started with nuclear cardiology, it was the cardiologist who made the decision, and the nuclear cardiologist really just had to get the cardiologist in their group or in their community to decide they wanted it. Over time, we've then seen the shift to hospital-based or institutional-based practice. And it then became important for the cardiologist as a group, led by the nuclear cardiologist, to make sure that the service line administrators were aware of the ongoing and continued value of nuclear cardiology and allowing it to expand. Over the last 10 years, we've seen an expansion of multiple technologies, such as CT, CTFFR, cardiac MRI. And then it becomes us to not only say we need to be able to do stress testing or provocative testing, but we need to be able to demonstrate why it's important. So when you demonstrate why it's important, first and foremost, you need to make sure that it's profitable. Years ago, when we started, nuclear cardiology was a profit center. People were putting up labs, they were doing testing. There was a little bit of lack of control on what was being done. We then put in the appropriate use criterion, for which the Health Policy Committee has been very active in advocating for its utilization. But it was a profit center for a long period of time, or at least wasn't a loss. Over the last 10 to 15 years, reimbursement has gone down, driven primarily by CMS, which is then dribbled down into the private community. And so the net profit and the cost, net profit decreased and the cost of doing a procedure increased. I think a good example is PET. Okay, PET has been available for quite a long period of time, but its penetration into the community has been small. Part of it has to do with the cost of setting it up. Part of it has to be the fact that we're not always getting reimbursed for it because of prior authorization. So health policy has really done two things. Number one, they've advocated for maintaining reimbursement. I think it takes 3 to 5 years for somebody who's on the health policy committee to really get a lot of experience and a handle before they'll be able to be a leader in promoting health policy. But I think if you're on the committee, within 1 or 2 years, you know enough to be a leader in your local community. And I think that's really very, very important to bring the information down to a level where everybody can benefit from it. Now, it may be your local ACC chapter, it may be your local health society, it may be working with the payers, but we need an expert in nuclear cardiology. And that expert in nuclear cardiology has to understand billing, and they have to understand health policy, and they have to be able to read a lot and interact with our government. We have a lot of meetings up on the Hill. We certainly used to go in person all the time. That's changed a little bit since COVID, but it's our job not only to bring the information to our community doctors, but also to our political leaders so they understand exactly what we need for the patients, why we need it for the patients, and therefore what we're asking so that service can continue to be provided.
Thanks for that answer, David. It really makes me think, as you were just explaining, cardiac imaging is under scrutiny from payers and the government as far as the total pot of money available to deliver both testing and patient care. And so in this environment, proponents of different imaging modalities have been tempted to promote their modality as the best test. While ASNC actually has embraced a patient-first approach, where testing choice is, we're striving for it to remain individualized. So how can we use quality data in positioning nuclear cardiology correctly within this patient-first paradigm?
All right, so I think that's a great question, and I just want to emphasize what you said. ASNC from the beginning has been patient-centered. What is the best test, and what information am I asking for? What am I looking for that I can get out of a test? And as we've evolved with nuclear cardiology, we've gotten more and more information out of each test. We started out with planar imaging, then we added SPECT imaging, and we added gated SPECT. Then we added PET, and now we're adding CT with coronary calcium. Then we added myocardial blood flow. So incrementally over time, we've taken the test whose goal is to diagnose and risk stratify for coronary disease. and expand it to more information. So you get a smaller pot of people who are at higher risk. And this data that we've had has been maintained over time. A lot of the other modalities have really still taken the surrogate approach. Okay. In other words, can I define a coronary obstruction? Or can I predict somebody who's going to have coronary disease at cath? But nobody has the body of data that really allows us to guide therapy based on the results of our test. And that's the information really that we have, that we should have, and we should be able to use to when we talk to the payers. We certainly need our own analytics. Okay, I think it's reasonable. The oldest analytic we had is how many patients who were cath had stents. I think a better way to look at it now are how many patients who have an abnormal stress test go on to cath and have normal coronaries. But I think it's a lot more complicated than that, because the test is only as good as how the person who ordered the test used the test. And I don't think that nuclear cardiology should be punished if somebody is using the test wrong. The AUC have been in existence for a long period of time. The first set of appropriate use criterion were in nuclear cardiology. The first revision of appropriate use criterion were in nuclear cardiology. Based on that, then, appropriate use criterion were developed for coronary angiography and then for revascularization. So it has to be really interpreted as a whole. If we're not a standalone imaging center, such as a radiology is, where they'll just necessarily say, it could be this, it could be that, it could be this. We're really very much focused on the results of the test and clinical management subsequently.
Yeah, that's really there's some paradigm shifts in there that we've seen over time, as you said, from just assessing, from doing risk stratification to how we measure how good our test is. And I do think we rely not just on quality data, but on quality data, meaning our data aren't just based on the quality of our tests, but our data themselves have to be of high quality in order to really do the right thing for the patient and maintain the central position that nuclear cardiology holds. For me, what I've been seeing is that the last decade has actually been really exciting for nuclear cardiology. When I first started, we were almost exclusively doing SPECT perfusion imaging. And now, as you said, we have a lot more tools. We have ways to assess for amyloidosis, sarcoidosis, viability. We've added PET perfusion, metabolic imaging. We now have flow. We have hybrid imaging, PYP. All of those things are now in our toolbox. Now, if you're thinking about this from a business perspective, what do you think is important to consider when driving change and actually helping folks adopt new tools like PYP or PET flow?
So I think amyloid is the best example. This is the disease that was underdiagnosed, underrecognized, and undertreated. In parallel, we had treatment come about for ATTR amyloid, but we also had the non-invasive test to diagnose the disease. And so people in nuclear cardiology really have been the leaders in not only diagnosing, but also in managing these people. And I think you have a new disease and you do a test that's positive, you bring more patients into your practice. People with amyloid are sick people. They do need management. They will require other things done to them. So from a business point of view, adding amyloid to your practice and amyloid imaging is really very, very important. I think PET, again, is a lot tougher nut to crack. We've seen that. There's no doubt that the value of PET is strong, but it faces competition of other modalities. But, PET is robust, and it allows you to get quite a bit of information. You can get coronary calcium, you can get perfusion, and you get myocardial blood flow, which I think is the best way to understand risk.
Fantastic.
So making these tools available increases our management option for patients, and then we'll bring other people in from the community.
Fantastic answers. And we all noticed the changes and the evolving changes with ASNC. But what can ASNC members and how they can work with ASNC to maintain and strengthen nuclear cardiology from policy and business perspective? What can be done?
So I think for many people, business and health policy may be a little bit boring, but you need to know a little bit about it. ASNC puts out Flashpoint on a regular basis, which gives you nuts and bolts information that you need to do. More importantly, when you have a question, ASNC is your reference, it's your resource. So take advantage of it and don't wallow around not knowing what to do with your practice or in your community. Reach out to ASNC, reach out to health policy. We have a lot of LDP now on the health policy committee that gives us broad kind of coverage. You can work with your senior cardiologists, even if they're not nuclear cardiologists, to spread the information. So I think it's very important to stay actively involved, at least in the minimum, by reading the flashpoints and follow up what happens when the draft rule comes out from CMS in July and the final rule comes out in November, December.
Yeah. Thanks, David and Friederike, for this great dive in the business of nuclear cardiology. I think a few takeaways here. Nuclear cardiology has always been evolving. Effective advocacy and policy have to be made to grow our nuclear labs. Nuclear cardiologists have to be aware of the challenges with billing and reimbursements. However, that will open a lot of opportunities to modernize their nuclear lab in modern imaging. And lastly, ASNC has a myriad of tools that made available for their members to enable to image the patient in the right time, and order the right test in the right time, right place to achieve patient fairness imaging. Thank you.
I say we'll do this again in another 40 years.
Yeah.
Here we go.
Yeah, I think this is a great summary, and I thank both of you for this stimulating conversation. And I would refer anybody who has additional questions to ASNC's website, to Flashpoint, and then also feel free to contact any one of us. That's the nice thing about ASNC that I found, is that everybody within the organization is just very approachable and always happy to engage in further discussions and answer questions.
I agree with everything that both of you have said. These are good times for nuclear cardiology.